You plated the culture, you injected the anti-serum. This was a life as a craftsman. As a result, we built it around a culture and set of values that said what you were good at was being daring, at being courageous, at being independent and self-sufficient. Autonomy was our highest value. Go a couple generations forward to where we are, though, and it looks like a completely different world. We have now found treatments for nearly all of the tens of thousands of conditions that a human being can have. We can't cure it all. We can't guarantee that everybody will live a long and healthy life, but we can make it possible for most. But what does it take? Well, we've now discovered 4,000 medical and surgical procedures. We've discovered 6,000 drugs that I'm now licensed to prescribe. And we're trying to deploy this capability town by town to every person alive in our own country, let alone around the world. And we've reached the point where we've realized, as doctors, we can't know it all. We can't do it all by ourselves. There was a study where they looked at how many clinicians it took to take care of you if you came into a hospital as it changed over time. And in the year 1970, it took just over 2 full-time equivalents of clinicians. That is to say, it took basically the nursing time and then just a little bit of time for a doctor who more or less checked in on you once a day. By the end of the 20th century, it had become more than 15 clinicians for the same typical hospital patient. Specialists, physical therapists, the nurses. We're all specialists now, even the primary care physicians. Everyone just has a piece of the care. But holding on to that structure we built around the daring independence, self-sufficiency of each of those people, it's become a disaster. We have trained, hired, and rewarded people to be cowboys. But it's pit crews that we need. Pit crews for patients. There's evidence all around us. 40% of our coronary artery disease patients in our communities receive incomplete or inappropriate care. 60% of our asthma, stroke patients receive incomplete or inappropriate care. 2 million people come into hospitals and pick up an infection they didn't have because someone failed to follow the basic practices of hygiene. Our experience as people who get sick, need help from other people, is that we have amazing clinicians that we can turn to, hardworking, incredibly well-trained, very smart, that we have access to incredible technologies that give us great hope, but little sense that it consistently all comes together for you from start to finish in a successful way. There's another sign that we need pit crews, and that's the unmanageable cost of our care. Now, we in medicine, I think, are baffled by this question of cost. We want to say, this is just the way it is. This is just what medicine requires. When you go from a world where you treated arthritis with aspirin that mostly didn't do the job, to one where if it gets bad enough, we can do a hip replacement, a knee replacement that gives you years, maybe decades, without disability, a dramatic change. Well, is it any surprise that that $40,000 hip replacement replacing the 10-cent aspirin is more expensive? It's just the way it is. But I think we're ignoring certain facts that tell us something about what we can do. As we've looked at the data about the results that have come as the complexity have increased, we found that the most expensive care is not necessarily the best care, and vice versa. The best care often turns out to be the least expensive. It has fewer complications, the people get more efficient at what they do, and what that means is there's hope. Because to have the best results, you really needed the most expensive care in the country or in the world. Well, then we really would be talking about rationing. Who we're going to cut off of Medicare, that would be really our only choice. But when we look at the positive deviants, the ones who are getting the best results at the lowest costs, we find the ones that look most like systems are the most successful. That is to say, they found ways to get all of the different pieces, all of the different components to come together into a whole. Having great components is not enough, and yet we've been obsessed in medicine with components. We want the best drugs, the best technologies, the best specialists, but we don't think too much about how it all comes together. It's a terrible design strategy, actually. There's a famous thought experiment that touches exactly on this. They said, what if you built a car from the very best car parts? Well, it would lead you to put in Porsche brakes, a Ferrari engine, a Volvo body, a BMW chassis, and you put it all together, and what do you get? A very expensive pile of junk that does not go anywhere. And that is what medicine can feel like sometimes. It's not a system. Now, a system, however, when things start to come together, you realize it has certain skills for acting and looking that way. Skill number one is the ability to recognize success and the ability to recognize failure. When you are a specialist, you can't see the end result very well. You have to become really interested in data, unsexy as that sounds. One of my colleagues is a surgeon in Cedar Rapids, Iowa, and he got interested in the question of, how many CT scans did they do for their community in Cedar Rapids? He got interested in this because there had been government reports, newspaper reports, journal articles saying that there had been too many CT scans done. He didn't see it in his own patients. And so he asked the question, how many did we do? And he wanted to get the data. It took him 3 months. No one had asked this question in his community before. And what he found was that for the 300,000 people in their community, in the previous year they had done 52,000 CT